They have a geni recurvatum on the lateral side. Check for the angulation of the PSIS and ASI. That will help you to see from the lateral side if there is any pelvic asymmetry. Always check if the shoulders and ear are in both level. If it is not, then it's mostly suggestive of kyphosis. So these are the basic things which we actually look into any individual who comes to you with any kind of pain. Okay, so keep that holistic approach whenever you consider posture. So your lower cross syndrome, 70 to 80% of the population has a weak core. And the reason, because of the weak core, repetitive bending forward or doing any kind of functional movement which involves multiple combination movements like flexion and rotation or flexion or side flexion, the disc, the joint are highly vulnerable to the injury. The focus should be more on the powerhouses, that is your core. Now that could be either a static core or the dynamic core. So Pilates here works, you have to incorporate Pilates into your later stage of rehabilitation to make your abdomen strong, because as far as the research are concerned, the abdominals are the primary reason for any person to get a lower back pain after your posture coming into the picture. So abdominals are weak with your glutes, also corresponding to the hamstring, and the tight muscles becomes your erector spinae, that is the postural muscles, with your iliopsoas. If you have a lower cross syndrome, there could be a dysfunction both going across your lumbar as well as your sacrum as well as your. Now this could have the implication above the spine and below the spine. So you can have a problem in the thoracic region because of this as a compensation, or you could have a problems in the leg because of any compensation. So difficulty in bending forward, side flexion, disc protrusion. Moving to the seated position is basically because of the lumbar instability and musculospasm. Only sitting is giving you difficulty to sit is basically a discogenic problem. Okay. Activity which aggravates pain, getting in and out of the car, you should ask the patients. Long sitting, if there is any desk job person. Then if you have any kind of issues related to your micturition or any kind of menstruation history, suggestive of either a myelopathy or the quad equina syndrome. So these are the basic history, which is a subjective analysis according to the Maitland concept we need to ask. So if we go on to the assessment and diagnosis, the approaches which is followed worldwide by all the rehab specialists is Jeffrey's, Maitland's mobilization and the assessment technique, right? But Jeffrey Maitland's method of assessment and diagnosis deals with the concept of examination, the concept of treatment, and it gives you a proper assessment, not just considering one connected tissue, but all the physiological system which we have listed on the slide number 1. And it also gives a special consideration to the pain and ROM. So it's come to that later on. Now, whenever you do a physical examination, okay, physical examination related to your Maitland approach, you have to go through this particular movement. First, you should always check the physiological movement, which is your basic movement of your lumbar joint, that is flexion, extension, side flexion, and rotation. You should ask the patient to do it actively. Then you do the movement, that is a passive physiological movement. Then you should always check the accessory movement, which makes sense. Then you should combine this active physiological and accessory movement, and then you need to perform the functional movement, like any kind of functional movement if the patient is doing, like sitting in the car and getting out of the car is his functional movement, or any kind of sweeper who is constantly bending down and moving, or any kind of warehouse worker where he needs to lift up weight, involve flexion and then rotation at the simultaneously. So assist them in that functional movement. And then special test. Take home messages, always try to incorporate functional movement, the movement which will give them pain in your physical examination. Now, the aim of this particular manual examination, why we are choosing Maitland, they specifically tried to identify and localize the symptomatic segment. Like lumbar has 5 segments, so L1, L2, L3, L4, L5. They will try to identify and see where the problem is. So they deal with a certain component which is at fault. They also identify the associated area of the segmental motion abnormality. Now, associated area could be either muscle or ligaments or tendon. This particular examination provides the basis for selection of appropriate treatment. Until and unless you don't know which particular segment is affected, you cannot really prescribe any kind of appropriate treatment for that particular technique. Whatever kind of element, than just holistically seeing the extension movement. And Maitland always take into consideration the pain as their primary factor and resistance as their primary factors. So active movements always needs to be done by the patient. It is always supposed to be performed first whenever you try to do with your physical examination because it's safe and the patient will perform within his own limit of pain. Okay. Severity of the disability, and it will give you a guide whenever you want to move ahead with your examination, that is the passive movements. So as you know that these are the first, so we are concentrating on the active physiological movement. So whenever you do active physiological, first it is safe, patient will do within their own pain limit. Then you can also, if the patient range of motion is severely restricted, that's a kind of a disability. You need to rule out that. And it will also give you a guide ki how much range of motion you are supposed to perform whenever you have to go into the next level, that is a passive movement. It will also give an idea about the quality of movement. Like when a patient is going into a flexion, you will come to know how well he is able to perform that flexion movement. Is he doing any trick movement or abnormal movement pattern or any kind of dysfunction which is there? Help you to understand whether the ligaments are okay. So why the Maitland works, why the Maitland approach is more acceptable. The second point is Maitland procedures are the only assessment procedures which incorporate ligaments also. Rest first see the available range of physiological movement in each vertebral joint. Palpated in the passive flexion, extension, lateral flexion, and rotation. Available ROM compared with the ROM for the intervertebral segment to detect if there is any hypomobility, hypermobility, or structural instability. Then comes the passive accessory movements. All the your glides will help you to understand the end field. What is the restrictive factor, whether it is muscle, skin, fascia, ligament, or cartilage. Now, so whenever you ask the patient to do a flexion, okay, the maximum range is 40 to 60 degree. The lumbar spine should move from its normal lordotic curvature to a straight curve. If that straight or slightly flexed curve is not seen, that suggests that there is a hypermobility in the lumbar spine because of the tight structures. Now, this could also be because of the higher grade of the slip disc. And the main point here is note how far the patient is able to bend forward. So the main goal is to see if the patient bends forward, there should be this particular loss of lordotic curve. If this is not seen, you should always judge that there is some kind of compensatory movement which is happening either from the thoracic spine to make that particular movement or from the sacral spine to do a movement. So whenever this was one patient who has come to us, and when we ask the patient to bend forward in standing, see that curvature is straight. There is no flexion of the curves. This would indicate that he is doing the movement either from the thoracic or taking into consideration the sacrum. This would also suggest that his erector spinae muscles at the lumbar region is super tight, which is allowing flexibility in the thoracic as well as the gluteal muscle to perform that particular movement. This is the Maitland's way of assessing. So you stand side to the patient, ask the patient to bend forward. Ideally, this has to be done by keeping the hands on the thigh, and you ask them to drag it down. Once the proper, if the range increases, that means the soft tissue was restricting it. If the range remains the same, that means joints are long. Clear? Now, the reason why Maitland don't work here and osteopathic approaches works more here is whenever you ask the patient to do a flexion movement in standing, he will always compensate with any kinetic chain, as I mentioned earlier, in the thoracic or the sacrum. So the best method to check flexion is always in the sitting position, where his pelvis is stabilized on the plinth, and then you can actually see the motion happening at lumbar region only. So you basically isolate the joints and focus more on the osteopath. To check the extension is always in a prone position. So you relax your other gluteal muscle and only focuses on the erector spinae muscle to perform extension. Sphinx position, where the hands are basically supporting your cervical, so you're not incorporating cervical motion here. So you're isolating the cervical motion to get a proper extension in the lumbar region. This is the Maitland's approach. Showing you when you give a passive physiological with the overpressure, you're stressing the ligaments which perform that movement. Like if supposingly if this patient is going into extension, his anterior longitudinal ligament with the overpressure is now getting stressed. So you can always identify the ligament involvement while you do overpressure with the Maitland technique. So all this is basically just having having the hands by the side and going downwards. You can also do the alternate stuff by hiking, and simultaneously you're going to get a side traction, or getting this particular leg down to encourage side flexion onto the opposite side. So these are the Maitland's way of doing it. Active. These are the passive ones with the overpressure. So the lateral shift, they focus. So if you do just side flexion, it's always the movement from L1, L2, L3, L4, L5. But you know, majority of the restriction happens at L4 and L5. So when you try to do a lateral shift passively, you're stressing the L4 and L5 level. You know, most of the, as you read it in the blog, most of the cases always comes at L4, L5, L5, S1. So if you're not stressing that particular part, you're not going to get any kind of diagnosis there. So it's very important that you do a lateral shift and check the movement happening at the L4 and L5. Is doing and see how bony landmarks we have marked it initially from all his cervical region to the thoracic, taking into consideration both the PSIs. If I need to just give a posture evaluation from the posterior view, you can see the distance between the trunk and the hand is slightly reduced here than the distance. This suggested that there could be a slight amount of scoliosis here. See compensated. See the shoulder level. This shoulder level is up. Then ear levels, this is up. So all these are the compensatory mechanisms. Now check how he is doing the forward flexion movement. Okay, now bend down. So you always ask the patient in his comfortable zone as much forward he could bend. Never ask the patient to go beyond it. You should always respect because this is an active physiological movement that the patient is doing in their comfort zone. Now, check how he is getting an adaptation of movement. Come on. Now this is the same patient where you see that his bend down again. When we ask the patient to bend forward, his lordosis was not being actually seen. It's completely flat. And if you can see it in front of the mirror, he's not going straight downward. It's slightly going a sideway movement towards his right hand side. It's not completely straight movement. So there are many kind of compensatory mechanisms happening which you need to start incorporating into your assessment charts. So this is basically a kind of a listing which we saw there. This basically deals with the spinal nerve. This is a chart taken from the Maggie. So if this says that if the disc is more lateral to the spinal nerves, to avoid pain, the patient shift basically to the opposite side. If he shifts to the same side, they will kind of going to get a referred pain. This is when the disc is lateral to the, lateral to the spinal nerves. They will always adapt to the opposite side. Vice versa, if the spinal nerve, if the disc is on the medial side of the spinal nerve in the vertebral foramina, they will basically go onto the same side because then the spinal nerves won't get impinged. Lumbar, and your fingers would be palpating the intersegmental movement of the facet joint. Little technical to understand, but try to grasp it as you go. So this is in flexion. So passive physiological stuff, according to the osteopath. Okay, this is now we are coming to the osteopathic approach, but Maitland's principle. Okay, so Maitland principle, we have only taken from Maitland the active movement. For passive, we are focusing more on the osteopathic approach. Like from L1 comes first, L2 comes first, L3, L4, and L5. In reverse, it's always L5, L4, L3, L2, and L1. And the major restriction is had L4, L5, L5, S1. So try to focus and move that particular vertebrae first, rather than targeting the L1, L2, L3. Okay, so this is the passive physiological, where the patient is in the sideline position and you do a hip knee flexion. When you do a hip knee flexion, that is simultaneously doing a flexion in your lumbar spine. Similarly, if you go to the hip extension, it's like a relative extension to your lumbar spine. The main advantage is the muscles are all relaxed in this particular position and you're going to do it passively. So involvement of the patient is not there. And the only structures you're targeting here is the facet joints and the bones and the vertebrae. This is the extension. This is the side flexion. So in the sideline position only, both the leg into hip knee flexion, bend the knees at the 90 degrees and move up and down. This is the another way of doing a side flexion, but a compression way. And this is the rotation, where your fingers are basically evaluating at each level.
And I'm going to go down one. I'm going to use her knee on my top of my thigh with my hand on the knee. I'm going to rock back and forth, inducing flexion. And I'm opening up the space between L5 and S1, separating the spinous processes. And I'm feeling that gap, that opening up in through there. Now again, if I have any doubt, I just go down to the sacrum and see what's happening with the sacrum. Yeah, it's not moving, it's fused, it's fused. Where does it start to move? Right here. So I know through motion how many 5 junction. You can start with the crest, and then you can confirm it. So you drop the knee down a little bit, and again, a table that can go up and down is really useful here, because everybody's at different heights, so you're going to need different table height. This table works okay for me. So my middle finger is between 5 and 1. I'm assessing the quantity and quality, going to the end of range, knee vesicle.
So every time he moves the hip knee flexion up to a certain new level, he's checking at each segment with his middle fingers on the spinous process and his index fingers onto the transverse process.
Little give and play, and any reactivity. Then I go up 4, 5. I'm using the hip to recruit the lumbar vertebra. Under the ankle here. But I'm just my body mechanics. I'm not working hard at all. My lumbar spine is in neutral, and I'm just hip hitching, moving at my hips. 2, 3, 4. And you want to start thinking, how does this correlate to what you saw with active movement? You observed flexion, and you saw maybe there was more motion in 3, 4 than in 5, 1. Is that what you feel? Another scale. Go all the way up to L1, L2. If you want to do TL junction, you can do that. A lot of back pain comes from T12, L1. That tends to be a little bit hypermobile. Go right up to that. So that's flexion. Then extension is a little tricky. I have 2 ways. In the first edition, I just had one, but in the second edition, I put in the alternative approach, which I like. I'll show you that. I find 5-1, and I use the hip, drop down, and I extend the hip to flex the sacrum, to nutate the sacrum.
This is extension of the lumbar
and then flexes
by doing
4, 5, and flexes
extension
3,
at
4,
the
right up to
pelvis
12.
and hip.
The alternative is really nice. You just come in, straighten your bottom leg. Extend. Sorry. The alternative is nice. You just come in under the waist. Like that. See my hand? And I put this palpating finger on 5-1.
Advanced.
I pull her with will be hypermobility. So I'll do the prone instability.
See how they concentrically check on each
3,
segment.
4, 2, 3, 1, 2. Pulling into extension. Lots of ways. I wrote the preface. I like with the books. I get a chance to go back and to understand what style. So let's not worship a technique. It's that you're getting the job done. There's another option.
This is side flexion. So take both hip and knee.
Now I'm going to use the legs to induce the side bending. So side bending, we palpate on the ipsilateral side. This is side bending left. So I'm going to put my palpating finger between 5 and 1 on the left side of the interspinous space. I'm going to do this to the lower limbs to get the side bending left. 4, 5, 3, 4, 2, 3. This could be tough. If you're 95, 100 pounds soaking wet, and your patient's 2 mechanics. You have one body there, uppermost side for side bending like this.
This is another way of doing side flexion, but the compresses it. And you're basically checking the movement at the intervertebral joint.
And then rotation.
This is rotation.
Straighten your bottom leg. I'm going to come in through the top, and I'm now going to start from the top.
In rotation, basically he did a little bit of rotation of the thoracic spine to isolate the thoracic spine. And now he's more focusing on the lumbar spine, but he's rotating through the PSIs, like taking pelvis into consideration. Check that.
4, 5, 3, 4, 2, 3, 1, 2. Between 2 and 3, rotation is contralateral. So if she's rotating left, I'm going to be on the bottom side. I'm going to induce rotation from above. You don't want to be straight at a right angle. Because you kind of feel that's the best. But you're better pushing off your back foot. I'm pushing off my right. Palpating underneath here. Almost giving a little assist here. I'll show you a thrust technique for the lumbar. You actually thrust through this arm a little bit. Coming in 1, 2, 2, 3, 3, 4, 4, 5, 5, 1. Feeling on the out of side. Here. Here's something to think about. If I take her towards me, what rotation am I inducing?
This is another way of doing a rotation, but in a prone position.
It's always the rule of the superior vertebra. So if I take her hips to the left, I'm rotating 5, 4, 5. I'm rotating 5 relative to 1 is going into left rotation. So I'm see? Relative to hitting on the right. 4. This was the biggest.
This is another way of doing a side flexion in prone.
For stability. Maybe we were making here.
So this is a side flexion
I'm on the left.
in a prone position.
4, 5, 3, 4, 3, 2, side bending left.
So that is how basically we are short of time. That is how you basically try to judge the movement at the intersegmental, like really focusing on